Hello, I'm Dr. James Bogash, expert in health and longevity, and today we're going to talk about a topic that is definitely sensitive, and as always, I would just point out that I'm the messenger, providing the information and kind of clarifying some of that, but these are going to be some messages that people might not want to hear because it completely flies in the face of the emotionality that had happened in the past 2.5 years. And this has to do with what's called the infection mortality rate, and that is the amount of people who are infected by something that actually ultimately die. Now that is far less scary than or generally far less scary than the case fatality rate. I said generally because something like Ebola, you know when somebody gets Ebola and their odds of making it are probably pretty slim. However, there are a lot of conditions like influenza and COVID that a lot of people are asymptomatic or minimally effective, and they never are minimally affected and don't report anywhere. So they don't go to the doctor's office, so they never really went into, they were never recorded as having it. So an infection fatality rate is generally less scarier. A case fatality rate is but is generally scarier. Initially, we were only testing people that were sick. So when you test people that were sick and hospitalized, and that percentage of people are definitely going to be sicker and more likely to die. When we've had some time to kind of step back, and quite frankly, we had this data early on, we look at the actual infection mortality or infection fatality rate of COVID. And this study was done it was looking at data seroprevalence, so people who actually, their antibodies showed that they were exposed to COVID, not based on report. So that number could actually be a little lower, which would then change these numbers for the better, but this is all pre-vaccination stuff, so we're looking on when things were worse and the SARS-CoV-2 was more dangerous and we had less ability to fight it off. We hadn't learned a lot of stuff yet, like low-dose hydrocortisone and not to intubate and prone intubate. Like a lot of stuff has changed. But this includes all of that. And looking across 40 different studies, across 38 different countries, this is a pretty big snapshot of the world and what the numbers were at. Now, before I start this, two things to mention is that, first of all, these numbers are generally looking at the non-elderly, so the under 70, because 94% of the population of the planet is under 70. And so it's not, I'm not suggesting that the elderly that anybody over 70 is disposable and we shouldn't care about them. That's not it at all. But when we're making policies, we need to have this information because those policies can be drastically different for somebody who's at higher risk versus somebody who's at lower risk. The other thing is that the influenza, generally it fluctuates depending upon the influenza, but the infection mortality rate is generally about 0.14%. So that's, 14 people out of 1,000 that can die? Don't quote me on that. And that's all ages. So it's really hard to get infection mortality rates for the flu, but that's kind of assumed it's about 1.4 is a generally accepted number. So when you looked at these studies, now another thing that's important is that there was a wide variation in countries on fatality rate. Well, that makes sense. Highest on the list is USA, Mexico, Italy, Germany, and England. No matter how we looked at it, those countries generally did worse because we don't want to admit it, but we're sicker countries. And so obesity is much more of a prevalence. Metabolically unhealthy people, the reality is those people were more affected. But when we looked at globally the infection mortality, infection fatality rate of those under 59, let's go under 69, so under 70, or 70, under 70, was 0.095. Like that's a pretty low number. If you drop it down to 0 to 59, it's 0.035. percent. So those are really pretty low numbers. We break it down even more, the 0 to 19, so we start from the bottom and move up. 0.003, so 3 zeros. So that's 3 out of every 10,000 persons or kids, pediatrics who are affected, will end up succumbing to COVID again. And then 20 to 29, that's 0.003, so 3 out of 1,000. Almost exclusively those have comorbidities associated with them. So we kind of look back, there was a lot of emotion tied to this, and yet how much of this was based in reality? And I'd say, well, we didn't know back then, but we really did. We had some indications that maybe this wasn't it wasn't everything that people thought that it was. And still, my gosh, Twitter is still a scary place, and you think that we're all going to die tomorrow, but we now have we have the opportunity to look back and look at the data with an objective eye without looking at it subjectively with our emotions attached, and that we never should have done that. For public policy decisions, it should always be a data-driven decision, and we did not do that at all. I've certainly pointed this out multiple times. The other thing we did not do is we did not help people move from having comorbidities to, hey, maybe we should exercise a little bit and get some sunlight. There were no recommendations for that. If they were buried under a list of interventions that was going to make the drug companies make lots of money. I'll put these particular IFRs in the description. Make sure you like this video, share it with somebody who you think needs the information, and subscribe to the channel.